Welcome to RWJBarnabas Health's Health Talk Show. I am Dr. Douglas Oshinsky of RWJBarnabas Health Medical Group. May is National Stroke Awareness Month. Stroke is one of the leading causes of death in the United States. On today's show, we will learn about the signs, symptoms, treatment options, as well as prevention strategies related to strokes. We are pleased to welcome Dr. Gaurav Gupta, Associate Professor of Neurologic Surgery, System Co-Director, Cerebrovascular and Endovascular Neurosurgery at RWJBarnabas Health, affiliated with Robert Wood Johnson University Hospital and the Bristol Myers Squibb Children's Hospital at RWJUH. And Dr. Srinivasa Patluri, board-certified neurologist and clinical neurophysiologist at Robert Wood Johnson University Hospital, Somerset, and a member of RWJBarnabas Health Medical Group. Welcome to the show. Thank you, Dr. Gupta, and thank you, Dr. Patluri, for being here. First, for the studio audience, as well as for the people who are watching this on the TV, can you tell us a little bit about who you are, your background, and where you practice as part of RWJBH?
Sure.
First, Dr. Gupta.
Thank you. I'm a vascular neurosurgeon. I work at Robert Wood Johnson in New Brunswick and Rutgers Health. My expertise specifically in brain surgery is the treatment of stroke, whether that is a bleeding kind of stroke or a hemorrhagic stroke.
And your background? Medical school?
I went to medical school in 1992. Then I did a 3-year fellowship at Albert Einstein College of Medicine in the Bronx. Then I came to Columbia Presbyterian Medical Center for my general surgery training. Then 7 years of neurosurgery training at New Jersey Medical School, followed by a fellowship in endovascular neurosurgery, which is the treatment of vascular disorders of the brain. And fast forward, I've been the director of the New Jersey Brain Aneurysm AVM program for about 11 years now.
Thank you. And Dr. Patluri.
Yes, good morning, Dr. Oshinsky and Dr. Gupta. Thank you so much for this opportunity. My name is Srini Patluri. I'm currently the Chief of Neurology at Robert Wood Johnson, Somerset, where I have been serving as an attending neurologist for the past 20 years. I'm also the medical director of the hospital's primary stroke program. I see patients both in the hospital as well as at the medical group's Bridgewater Hub, which is part of the Robert Johnson Barnabas Health System's combined medical group. My background, I have trained in neurology at NYU. I finished my fellowship in neurophysiology in 2001 and have been in practice in New Jersey since. And I am board certified in neurology as well as in clinical neurophysiology.
Thank you both for being here. Stroke, that's what we're going to be talking about. It's a 6-letter word, but it really is a big encompassing word. Can you tell us what a stroke is and what are the different types of strokes that there are?
Okay, let me take the first part of this question then. What is a stroke? So basically a stroke is a disorder caused by a disturbance in the flow of blood to the brain. It can technically affect the spinal cord as well, but primarily the brain is the organ that we're concerned. It is suspected when a person experiences a rapid onset of any number of neurological symptoms due to such impaired function in the brain. And maybe Dr. Gupta can answer the second question, which is the different types of strokes.
Sure. In our body or in our brain, there is no free-flowing blood. Everything is inside pipes, which we call arteries. The arteries take the blood from the heart to the brain or to the other organs, and the veins bring the blood back from all over the body to the lungs and heart. So if that particular blood vessel becomes occluded, physically occluded by a clot or some calcium that comes from the heart then that's called an ischemic stroke. And downstream, the brain, part of the brain that is not receiving any blood anymore, gives rise to something we call ischemic stroke. So that is the commonest type of stroke. So if somebody says, my grandma had a stroke, 85% of the time, roughly, they mean an ischemic stroke. And then other 15% type is where the pipe, which carries the blood to the brain, actually bursts. So that's the bleeding kind of stroke, or what we call hemorrhagic stroke.
So we go through that again. The ischemic stroke, which is basically the one that's lack of oxygen due to a clot or some type of obstruction in the pipe, which is very similar to what people think when they talk about heart attacks. We have something blocking the movement of blood in the pipe so that the brain tissue that surrounds it and gets its oxygen and nutrients from is no longer getting that. It becomes ischemic, in other words, lack of oxygen, and it dies. And that's what causes the symptoms that we see. And that's the same symptoms that we go through when people go through their BLS testing. They learn all about the types of things that they see when someone has a stroke. The other stroke is the one where there's bleeding, which can be caused by an aneurysm, which is the bubbling out of one of the pipes, which we don't even usually know about until something happens to it, or if the person has a family history of it, or if there's something called an AVM, which can happen also. We see those in anywhere in the body. Most commonly, we see them in the bowels, and that's where the artery goes directly into the vein, and it's a difficult connection, and we can get a bleed that way. And the big reason why we need to know the differences is that the two are treated differently. So being that we are in an area of the country where we have very good stroke protocols, can you tell us what goes on when someone comes in with a stroke to the emergency room?
Got it. Let me take the first part of this question. Absolutely. So we have systems in place locally at all the hospitals around central New Jersey, but focusing mainly on what we do at Robert Johnson Somerset, which is a primary stroke center. If the hospital is alerted by the 911 system that there is a patient with potential symptoms of a stroke coming our way, then that's called as a code stroke, which is what's initiated. And the system gets ready to receive the patient. So the nurses and the ER doctors see the patient quickly, examine the patient, send the patient quickly for a CAT scan of the brain, which can help look for any signs of bleeding, either in the brain or around the brain. So the findings, those findings would suggest a hemorrhagic stroke, and like Dr. Shinsky was just saying, like you were just saying, the management changes substantially. On the other hand, if you don't see a hemorrhage in the brain or around the brain, we can assume that we're dealing with ischemic stroke and get ready to help the patient by giving a clot-busting medication such as TPA or TNK. We have to look at other problems such as glucose levels. We have to look at blood pressure, correct them as best as we can, and then start looking at the pipes carrying blood to the brain with tests such as CT angiograms, and thereby make decisions about the step after giving the intravenous clot-busting drug. Do we keep the patient in Somerset? Do we transfer the patient to the Comprehensive Stroke Center so that the patient can be assessed by and treated by an expert such as Dr. Gupta? I will pass this conversation on to Dr. Gupta so he can talk about what he can do for the patient.
So it's a team effort, and there are differences between what a primary stroke center as headed by Dr. Patluri, or if it's a comprehensive stroke center. The comprehensive stroke centers, in addition to having all the technology and the expertise of a primary care center, also has neurosurgeons 24/7, vascular neurosurgeons, or interventional neuroradiologists, or interventional neurologists, who are then able to do surgical treatment of stroke. Now, what that is that if, as Dr. Patluri said, you give the clot-busting medications, they're basically meat macerators, and they just dissolve the clot. But sometimes the clot is very big, and sometimes the clot cannot be dissolved with this medication, Or the patient, for example, if they've had recent surgery or GI bleed, they are not candidates for the clot-busting medications. That's where we come in. So what we do is we enter the highway system of the body. It's pretty much like our highway system. I-95 is connected to the Garden State Parkway. So we have to just take one of the ramps up towards the brain. The commonest ramps we take is right here in the wrist or in the groin. And then we take our tubes, small tubes from here all the way to the neck, through that another tube, through that another tube, and physically go to the place where the clot is obstructing the pipe, catch that clot, and bring it out. So that's the surgical treatment of stroke, ischemic stroke. However, as you mentioned, if it is a hemorrhagic stroke, then it depends upon the cause of hemorrhagic stroke. For brain aneurysms, which are pretty similar to a bubble on the tire of your car or bubble on the garden hose, the goal is to get rid of that bubble. We don't want any blood going in that bubble. We want the blood to continue to flow to the normal pipes. That cannot stop, but we have to shut the door, shut the neck of that aneurysm, or an AVM also. That's the goal of these surgeries.
So again, if we do an analogy, going into the wrist, going into the groin, very similar to the type of procedures we do in the heart when someone's having a heart attack and we're doing what's called angioplasty and possibly putting a stent in. Now, I don't know if we put stents into the brain, but instead of feeding it up to the heart, we're feeding it all the way up into the brain to try to do as much as possible and to limit any type of outcomes, poor outcomes, if we can prevent the stroke from being long-term.
Correct. The heart is exit 9 off the turnpike, and the brain is exit 10.
Just hope that there's not too much traffic on it.
Not too much traffic. Fortunately, we have the emergency shoulder where we can take our equipment up there.
And so the important thing about RWJBH is that we are a clinically integrated program. So we have both the primary stroke program as well as the comprehensive stroke center, both of which are in very good communication with each other, so that someone who can be initially handled at the primary, if suddenly we realize we need to move them to the comprehensive, we can get them there. And there's no lack of communication between the disciplines of medicine, between the primary stroke center and the comprehensive stroke center. Plus, the comprehensive stroke center sees how important the primary is, and there's no pushback on saying that we don't want them going to the primary. We actually want them to go to the primary, do what's necessary so that we can do what's best for the patient both in the primary and in the comprehensive centers.
That you raised a very interesting point. A lot of my patients from far away say that, oh, if I'm having a stroke, should I come to you or Robert Wood Johnson in New Brunswick? And my answer is no, you go to the nearest ER.
Which again, very, very important in a stroke to get to the ER as quickly as possible.
Yeah, it's no reason to go far away to a comprehensive stroke center. You go to the nearest ER or a primary stroke center.
Absolutely. So not all symptoms of a stroke are from a stroke, and not every stroke requires interventions that will delay the care of the patient. For example, if a patient can do just well with the intravenous clot-busting medication, then you're better off being seen at your closest hospital, the nearest ER, preferably a primary stroke center. But then, that's where the ED doc and the local neurologist can triage the patient. For example, I or my colleagues at Somerset would, if necessary, get in touch with the experts, such as Dr. Gupta at the Comprehensive Stroke Center, discuss the case, review the images, and make a decision about the necessity and safety of transferring the patient. So I think the initial triaging of what's happening, what is the best treatment, that's all best done at the primary stroke center, if that is the closest place for you to get to.
So again, important thing, if you have signs, symptoms, or question about a stroke, get yourself to the nearest emergency center as quickly as possible, and hopefully it's a primary stroke center where they can do all of this. So after this program is over, if the people are looking in the area, they really should look at where their nearest emergency room is, and to possibly contact them and ask them if they are a primary stroke center.
Well, so yeah, absolutely. And most importantly, I think the thing to do is to call 911 rather than get yourself into a car or get your loved one into a car and drive yourself. The process of receiving the patient and getting the systems ready to carry on the steps necessary for a stroke victim, those get into play much faster if we call 911, because the EMS services will then, in turn, find the best place to carry you, to take you to, and alert that place to receive you so that the systems are activated and everything happens as fast as possible. The key thing is to call 911 and let the EMS do their job, which is to triage the best place to get to for the care you need.
And give immediate treatment. For example, sometimes these first initial 5, 10, 15 minutes are the most important. If the patient has such a large stroke that they cannot breathe on their own, so our EMS technicians, nurses that are there, they're the ones who will put a breathing tube right there and then, so they can save a life out in the field, stabilize the patient a little bit, and on their way in the ambulance, and then bring them to the ER.
Okay, so stroke itself, what are the common symptoms that people should be looking at if they suspect a stroke?
The symptoms of a stroke depend on which part of the brain is not functioning properly. And the symptoms might include a fairly common problem such as a headache. Typically, it's a rapidly escalating and severe headache. There could be paralysis. The best way to remember some of the most common symptoms of stroke, so that one recognizes these symptoms and then calls 911 quickly, would be by using the mnemonic BFAST, so BEFAST. B stands for balance issues, so there could be a sense of dizziness, a sense of vertigo, imbalance. Those could be symptoms of a stroke. I stands for eyes, so vision disturbances, whether it's loss of vision, could be one eye, could be one half of both eyes, could be double vision. That can be a symptom of a stroke. F stands for face, or facial drooping, something you would commonly see in a paralysis type situation from a stroke. A stands for arm and leg. So any symptoms on one side of the body in the arm and leg, or sometimes the face, arm, and leg, such as weakness, heaviness, numbness, or tingling. And T, the most important one, stands for time to call 911, for the reasons we just talked about, so that you alert the system, you get everything in place to receive you, and do the best to optimize the outcomes.
And factors that people can do to lessen the possibility of having a stroke, the risk factors.
So the most common risk factors of a stroke would be a history of a previous TIA, or a so-called mini stroke. These are similar symptoms that one can expect from a stroke that are short-lived and don't necessarily cause brain injury. So that would be the highest risk factor. High blood pressure is a very common risk factor for future stroke, both of the ischemic type as well as the hemorrhagic or the bleeding type. Blockages in the carotid arteries in the neck, those would be a risk factor as well. And then a heart rhythm disorder such as atrial fibrillation, that is a fairly high risk factor for a future stroke as well. And then the common ones that are considered to be so-called vascular risk factors, these increase the risk of vascular disease in any organ in the body, whether it's the brain, the heart, or the circulation to the legs, for example. Those would include conditions beyond high blood pressure, such as high sugar or diabetes, high cholesterol, midlife obesity, inactivity, smoking. Those all would also be risk factors that are correctable, treatable, and preventable. Those are the big ones. And then to a certain extent, sleep apnea, that's not too uncommon, may also increase the risk of effusion stroke.
Now, we've been talking about the 24/7 access to both the primary stroke center and the comprehensive. Can you also tell us a little bit about the neurologic services that are provided in the emergency room and throughout the hospital?
Yes, absolutely. So with stroke, time is brain. We want to get the process to take care of a stroke victim as fast as possible. And in that process, one of the most important persons beyond the nurses and the emergency room doctors, once the patient arrives in the hospital, would be the neurologist. And the neurologist needs to see the patient, assess the patient, look at the imaging studies, the CAT scans, and make a decision. Do I keep the patient here, go ahead and give the clot-busting drug? Do I also call maybe Dr. Gupta and talk to him or his team about transferring the patient? So getting the neurologist involved quickly is important. And to facilitate this, the Robert Johnson Somerset several years ago made a decision to deploy what's called a teleneurology or a telestroke service. So these are board-certified neurologists who are waiting in a remote location using audio-video technologies to beam in as soon as they are alerted. And the beaming time is usually just a few minutes. They assess the patient with help from the nurse, and then they make these decisions as quickly as possible. So there's always a telehealth or a teleneurology provider waiting available for evaluating patients. And this happens both in the emergency department as well as on the floors of the hospital. If somebody has stroke-like symptoms elsewhere on the hospital floors, the nurse or the nurse practitioner or the hospitalist can initiate these calls and have a neurologist assessing these patients quickly. I remember in the early days of the intravenous clot-busting drugs, when we were in the office seeing patients, and you get a call from the ER, and you have to suspend the office hours, and then you have to get out, drive to the hospital, get into the ER. This is all time that we're trying to save now by deploying this systematic approach using a telestroke service.
And as you mentioned, the communication is key here. And while this is happening, we don't start the process from the neurosurgical side or neurointerventional side only when the medicine we know is not going to help. We start the process much earlier. So when the page or the beeper goes out to the stroke neurologist that there is a potential patient for stroke coming, it comes to us too. And that's where we start mobilizing our services so that if in case the patient does need a treatment, we are up and ready. Otherwise, we will waste precious time. Time is brain. We will waste precious time in getting our stuff ready because you have to get the operating room ready, the neurointerventional suite ready. So we keep it ready once the patient shows up at the door and all prepared to do the surgical procedure without minutes being lost.
Which is what makes RWJBH such a terrific organization, that we have such a comprehensive organization that everyone is aware of what's going on, and that there's no loss of time, no loss of steps, no loss of communication between anyone, and that the patient receives the best overall care in both the community hospital nearby their home, as well as if they need to be transported over to University Hospital, the best care possible for whatever disease they've got.
Correct. I mean, imagine in every minute that is lost, we lose 2 million neurons every minute. And I have a joke which runs in the neurointerventional suite that every minute, actually it's 3 million neurons. The patient loses 2 million, and I lose 1 million if we are late. We try to do it as fast as we can.
And what does the recovery process look like after a stroke?
Yes, so the recovery process requires input from a multidisciplinary team, and we try to mobilize the patient as quickly as one can, and this is done both by the nurses and the rehab specialists seeing the patient. The rehab teams at both institutions are again multidisciplinary. We have physical therapists, we have occupational therapists, speech and language pathologists, and they're looking at all the aspects of the patient's well-being. They're looking at the physical limitations. They're looking at any swallowing issues, any speech issues. They're looking at any cognitive issues. So we try to get the rehabilitation portion start in parallel with the diagnostic and treatment portion as quickly as possible as well. And the process of rehabilitation continues through the hospital stay. And once all the testing that's necessary, consultations that are necessary have been accomplished, we have a plan as to how to prevent the stroke from happening again, and also to reduce the progression of the stroke and minimize the disability from the stroke. We make a comprehensive plan in consultation with the patient as well as the patient's family members, and figure out what is the best place for the next phase of the treatment/recovery to happen. Is it best done at home with outpatient therapy? Is it best done in an acute rehab system or facility? Or is it best done at a subacute rehab system or facility? And once that decision is made, the patient is transferred over there or discharged with the recommendations, and the rehabilitation process continues. These are exciting times. There's a lot of interesting work that is coming out of the research field in terms of promoting neuroplasticity, which is the brain's capacity to rewire and regenerate. There's a lot of work that's coming out of the...
Which is probably a lot having to do with what Dr. Gupta does, since RWJBarnabas Health, in partnership with Rutgers Health, provides the comprehensive range of educational programs, research opportunities. He probably has a lot of research on neurosurgery going on at the hospital.
Correct. We have a very robust team and a research team that we participate with other centers of the nation. Those are multi-centric trials. And what we're looking at is that what is the optimal time that we can go up until, for example, earlier, if the patient comes within about 3 or 4.5 hours, you can give the clot busting medication. Up to 6 hours, if they come, we take them directly for thrombectomy, which means to pluck the clot out. However, what about the patient who went to bed completely normal and woke up? Those we call wake-up strokes. They are technically out of the window because we consider them the last known normal for this patient was 10 p.m. when they went to bed. Can we still do surgery at morning 7 a.m.? So those are the really research projects which are spearheaded. And now, thanks to new imaging technology, something we call CT perfusion or artificial intelligence guided CT perfusions, we are able to make a decision that, look, this patient, even though they had a stroke about 12 hours ago, only a small portion of the core is completely unrevivable. However, there is a much larger area around the core that we can still protect. So now, most recently, in the last 2 or 3 months, we now have good data from multi-centric trials from all over the world that for some candidates, we can even go up to 24 hours. So imagine where the technologies come. The second part of the technology is our devices. I remember 2007 when I was a fellow at New Jersey Medical School. If a stroke case came, and if we were to do the surgical treatment of the stroke, that was a 4-hour, 5-hour case because our devices were not good enough. We really did not have good devices to quickly go up. Fast forward 2023, last week, we did a case in 11 minutes. Imagine going from the groin to the brain, the catheters and the tubes within 11 minutes, pluck it out. So that's where the technological advancements have taken towards the treatment of stroke.
Thank you. Thank you both for being here. Thank you both for all that you do for the RWJBarnabas Health System. Thank you for being members of the primary stroke center. And thank you, Dr. Gupta, for running the terrific comprehensive stroke center and all of the vascular and neurosurgical outcomes and future research that's coming out.
Thank you.
Glad to be here. Thank you.
That concludes today's episode of Health Talk. Please remember that the opinions expressed here today by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call 888-724-7123. For more information about stroke treatment at RWJBarnabas Health, please visit www.rwjbh.org/STROKE.